what can we discuss in the context of some of the emerging therapies. Now, in MS, patients have been exposed to the full gamut, ranging from antigen-specific attempts at modulating those few cells that are thought to be the putative bad guys, all the way through to completely ablating patients with high-dose immunoablation, chemotherapy, and then reconstituting their immune system, typically with autologous CD34 positive hematopoietic stem cells. And very simplistically, one can consider changing the profile of these drugs as you move through the spectrum from those that might be viewed as rather safe because they only affect those particular bad guys without impacting the rest of the immune system, but may not be as effective, to drugs that have been showing increased efficacy, but of course at a price. Now, our approved immune modulators are sitting here: interferon betas, letermovir acetate, natalizumab, mitoxantrone, a chemotherapeutic, also approved, belongs to the immune suppressive family. In brackets are medications that have not been approved. So really these represent the approved therapies. The antigen-specific therapies, none of course approved, but I'll put in brackets. We may want to discuss these at the end if we have time. They have certainly taught us some very important things about the capacity to modulate antigen-specific responses in the periphery of MS patients and change the face of the disease within the CNS. So that's a sort of proof of principle, but we've also run into problems where, for instance, the altered peptide ligand of MBP actually induced new brain lesions rather than diminished new brain lesions. So we need to learn how to safely bring this type of treatment to bear, because it does continue to have certain attractions. Fingolimod, or Gilenya, I'll talk in some detail about, has just recently been approved in the US and Canada for the treatment of relapsing remitting MS. And if we have time at the end, we'll talk a little bit about selective depleting therapies, including anti-CD20, B-cell directed, and anti-CD52, a much broader depleting agent. As far as a very brief, really brief overview of the presumed mechanism of action of the already established therapies. These are therapies that have been in the MS world for approaching a decade and a half, 2 decades. Interferon beta and letermovir acetate, they're all injectables. Interferon betas work through targeting interferon receptors on multiple different cells, not just immune cells, but in context of MS-relevant immune pathophysiology, they're thought to decrease T-cell activation, perhaps change profiles of Th1 to Th2, but certainly impact the interaction with the barrier by decreasing substantially the capacity of these cells to upregulate adhesion molecules, and by directly impacting their capacity to produce the matrix proteases that need to actively break down the barrier for cells to invade, so that translates into less inflammation within the CNS. Letermovir acetate, a very interesting copolymer of 4 amino acids, GLANT, works, we think, as an antigen, which modulates the profile of antigen-presenting cells more to a type 2 APC, modulates populations of T cells more to a Th2 rather than a Th1 or Th17 profile, and probably induces regulatory cells as well. So these changed populations contribute to less inflammation in the periphery, and the thought is that these cells, because they're activated as Th2 cells, have the machinery to get across the barrier, but there, through bystander suppression presumably, decrease inflammation. So that's really a very short overview of how we think these very established therapies work.